So male factor infertility is very important, and in the whole world, the incidence of this male infertility is increasing. And UK says, in the UK guideline, they say that 30% of the all cases of infertility are because of the male factor. And then we read in the ACOG guideline that almost 40% cases, they are because of the male infertility. So we need to be very careful about it. And 40% of all cases, they will have both male and female factors, and 30% will be unexplained, like that. Okay. So then infertility, this is a diagnosis that can have considerable physiological, psychological impact on the man concerned, his partner, and their relationship. So then if there is like male infertility or female infertility is there, the level of anxiety, depression, paranoia, compulsion, and even psychosis, it increases in both partners. Okay, that is the problem. So before we start talking about the male infertility, we should know about some basic definitions, like what is oligozoospermia. It means a reduction in the concentration of sperm. So the concentration of sperms is less than 15 millions per ml of the ejaculate. Then asthenospermia, it means a reduction in the motility of the sperms, like less than 32% are motile. Ideally, 50% should be motile. Then teratospermia, it means reduced sperm percentage. It means that less than 4% of the normal shape present in the semen. Azoospermia means no sperm in the ejaculate. Aspermia means there is no ejaculate at all. So it is dry, no ejaculate. Then necrospermia, it means that only dead cells are present in the semen. Then globosospermia, it means abnormal sperm morphology in which the acrosome is completely absent. If they ask you which one is the most common abnormality of the male sperm parameters, you will say oligoteratoasthenospermia. It is the OAT, OAT is the most common diagnosis in male subfertility, and Caucasian men between the age of 15 to 40, they have the highest incidence of testicular cancer or testicular germ cell tumors. In which age group? 15 to 40. How do we assess if a man is infertile like that? So male factor alone, it contributes for up to 30% of subfertile couples undergoing IVF. Male infertility, it may be due to problems with sperm production or transport, and also sexual dysfunction. So the underlying cause is most often idiopathic, where we have no clue that what exactly is causing male infertility. Modifiable lifestyle factors, they can have an impact on male fertility, but medical treatments, they have limited value in enhancing semen quality. The number and quality of sperms that can be recovered either from the ejaculate or surgically, it determines the available options for assisted conception. Intracytoplasmic sperm injection, it is considered relatively safe. However, because of the ability to bypass the natural barriers to conception, there are concerns regarding its potential to transmit genetic defects. So that it is estimated that 1 in 7 couples in the UK, and the same number, like they say that 10 to 15% of the couples in USA, they experience some difficulty conceiving at some point in their reproductive life. ACOG guidelines, it says that this number can be as high as 20%. Like 20% of the couples, they can face some problem at any point during their reproductive life. 16% of the couples, they will fail to conceive after 1 year of trying. So it means that if the couple is trying, then 86% chance that they will conceive in 1 year. A male factor alone is thought to contribute to up to 30% of the cases, and female factor affecting 40%, and remaining 30% they will be unexplained. What is the epidemiology of male infertility? It is difficult to estimate the prevalence of male infertility in the general population, as reported fertility rates are dependent upon numerous factors such as what is the coital frequency, and it may not reflect the biologic fertility. Demographic data shows that male factor infertility, the incidence is rising. Like in just 6 years, the incidence rose from 27.6 to 32.5. Okay, so that is important because some changes are occurring which we are not able to find out right now. The evidence that sperm counts they may be declining, it has been linked to the theory of testicular dysgenesis syndrome, TDS, which comprises a developmental disorder with increased rates of testicular cancer, undescended testes, and congenital malformations. What are the causes of the male infertility? They can be divided into many causes. There are different ways of classifying them. Like we can say pre-testicular, testicular, post-testicular. Otherwise, we can divide them into endocrinological defects, anatomic defects, then secondary to other diseases. Then there can be problem with the passage. Okay, then maybe they are having it because of exposure to the radiology or cytotoxic drugs. So many different pathologies can be there. So easier way is to divide them into pre-testicular, testicular, and the post-testicular causes like that. Okay. So the pre-testicular hypothalamic causes. The hypothalamus is producing gonadotropin releasing hormone. So maybe there is deficiency of the gonadotrophins, like it occurs in cases of Kallmann syndrome. The patient will have tiredness. He will have no sense. The male will have no sense of smell. Okay. Then we have to think about Kallmann syndrome. After this gonadotrophin hypothalamic disease, patient can have pituitary disease. If the disease is in the pituitary system, then we say that patient has Cushing's disease. Like there can be pituitary insufficiency. Why? Because there are certain tumors can be like in the anterior lobe. We are not concerned about the posterior lobe, but the anterior lobe tumors. Then secondary to radiation, cytotoxic drugs, or surgery. Hyperprolactinemia. Okay, hyperprolactinemia means like there is deficiency of the gonadotrophin. So if the gonadotrophins are normal, then prolactin will be low. If prolactin is high, then it means that gonadotropins are low. Then the exogenous hormones like anabolic steroids, glucocorticoids excess, hyper or hypothyroidism. All of these are important. In testicular causes can be congenital or they can be acquired. Among the genetic causes, we include chromosomal abnormalities like Klinefelter syndrome, where the male will have genetic makeup of 47XXY. Okay, so this is like the number one cause of the number one known cause of the male infertility. Then there can be Y chromosome microdeletions. Noonan syndrome, which is said to be equivalent of the Turner syndrome. In the Turner syndrome, we have 45X0, so similar condition in the male. So then there can be other causes like cryptorchidism, like the testes are very small, they are small congenitally. Okay. So then the acquired causes, like the male was born and was fine, but then he has become infertile because of acquiring some condition. Like maybe he sustained some injury. The injury can be like physical injury. It can be due to some infective process, or it can be due to some physical process or some autoimmune origins. So injury can be orchitis, like inflammation of the testes, then torsion, like the young male, they will give you a typical story that he just kicked the ball and after that he had severe pain, some process was done. So maybe there was this testicular torsion. So then we have to do this archidopexy, like just like in the female, like you are correcting the detorsion. and then you are fixing it to the pelvic wall. So in male you will have to do the same thing, so we call it archaeopexy. Then if it may be secondary to trauma. Then in the acquired causes, varicocele. What is varicocele? Like patient was, maybe the patient had severe constipation, had hernia. So what happened? The testicular, the venous plexus of the testicular veins, it can be felt. So we can see that something was palpable in the groin like that, in the scrotum like that. So varicocele. Then it can occur secondary to the systematic diseases like renal failure, hepatic failure, exposure to chemotherapy, radiotherapy. Then testicular tumors themselves, like they destroyed the cells. Then idiopathic, where we don't know that what has caused it. Post-testicular, it means like there is obstruction. So it can be congenital. Congenital, when in cases of cystic fibrosis, there is absence of the vas deferens. Then it can occur in the Young's syndrome. Among the acquired causes, maybe the male person underwent vasectomy at some stage in his life. Then it is blocked because adhesions are formed in chlamydial infection, in gonorrhea. Then maybe there was some iatrogenic vessel injury and disorders of the sperm function or motility. Like the person is producing them, but they are not normal, like immotile cilia syndrome or Sertoli cell syndrome, where what is happening in the immotile cilia syndrome, the sperms are formed, but they are not mobile, like in Cartagner syndrome, like the ciliary action is defective, so they are not moving, and we know that they have to be motile like at least 32%, so that conception would occur. Then there can be maturation defects, like you know that sperms are formed, then they undergo spermiogenesis, the maturation process. So maybe there is deficiency of enzymes in that pathway, so the patient is having these defects. Then there can be immunological infertility, and then there can be like overall some problems in the sperms. Then there can be sexual dysfunction, like the patient has some psychological stress, can't perform the act correctly, or has low desire, low libido. Depression is there, so many different things can be there. Okay, so we have to be careful about many things. That is one thing. Okay, so let's go to the next one, which is sexual dysfunction. Then maybe the timing and frequency of the coitus is not normal. It is not around the time of ovulation. This person can have erectile or ejaculatory dysfunction. Then maybe he is having some problem which is secondary to the systematic diseases, like patient has diabetes mellitus, multiple sclerosis, spinal cord, and the pelvic injuries. So how do we regulate spermatogenesis in the young adult? Sperms are formed in the seminiferous tubules from the germinal epithelium, which are cells which are called spermatogonia. Spermatogonia, by the process of mitosis, they divide into primary spermatocytes, which then undergo two reduction divisions, meiosis 1 and 2, to form spermatids. And by the process of spermiogenesis, spermatids, they transform into mature cytoplasm free sperm with condensed DNA in the head, an apical agrosome, and a tail. Then the normal spermatogenesis is under the influence of follicular stimulating hormone and testosterone. FSH binds to the receptors on the surface of the Sertoli cells and increases spermatogonial number and maturation to the spermatocytes. But the Sertoli cells, they are unable to complete the spermiogenesis alone. FSH cannot complete this spermatogenesis alone. So luteinizing hormone is necessary for testosterone production by the Leydig cells and plays an essential role in the spermatid maturation. The entire spermatogenic process, including the transit time in the ductal testicular system, it takes approximately 3 months for maturation. So the causes of male infertility, like we have just talked about them, so the conditions that act at the pre-testicular level, they tend to be hormonal in nature, and most of these can be treated with hormone manipulation. Causes at the testicular level, they are largely irreversible, but they can be treated with assisted reproductive techniques if the sperm is retrievable. And the post-testicular causes, they can be treated with microsurgery or with assisted reproductive techniques. It is estimated that in about 50% of men with poor semen quality, no cause for this will be identified. So, what is the role of male age? So, male age has been shown to have an impact on fertility and health of the offspring. If the paternal age is more than 35 years, it halves the chances of achieving pregnancy compared with the paternal age of less than 25 years. The effect of age on male fertility is more noticeable after the age of 50, with a concomitant increase in adverse outcomes in the offspring. For this reason, the age of the semen donor is limited to 40 or 45 years in some countries. Environmental, occupational, and lifestyle factors, they are also important. Occupational exposure to certain chemicals, it can affect semen quality. These include heat, X-rays, heavy metals like lead, mercury, glycol ethers, highly volatile compounds, and they are used as solvents. And the pesticides. The pesticides also have some effect. Like organophosphate compounds, they can have some effects like that. So as well as documented example being like dibromochloroproene, and that is like a nematocide. Nematocide means that this is also used in the fertilizers, and it can have like toxicity. The exact mechanism by which these occupational substances they affect male fertility, it remains unclear. Testicular hyperthermia, it may affect semen quality. However, there is no clear evidence that wearing loose-fitting underwear it will improve fertility. But the testicular temperature, it is 2 degrees centigrade less than the abdominal temperature. So better we will tell the patient not to wear the plastic or the spandex underwears. But we don't exactly know right at the moment that what is the effect of wearing tight dresses, but it is associated with a decrease in the semen parameters. Obesity is an important lifestyle factor that has been shown to be associated with poor semen quality, and through an imbalance of the reproductive hormones level, as obese men, they have reduced sex hormone binding globulin and elevated serum estrogen level. That is the problem. Anabolic androgenic steroids, they may induce azoospermia by interfering with the hypothalamo-pituitary gonadal axis. Like if the patient is taking them from outside, like the person is a bodybuilder and he is eating these steroids, so they can have problem. They can suppress the normal functioning of the male organs like that. So they may also inhibit male reproductive function through loss of libido and erectile dysfunction, which will be secondary to low endogenous testosterone levels. Azoospermia, it may be reversed by a conservative management when the drugs are discontinued, especially in non-heavy users or by administration of human chorionic gonadotropin and human menopausal gonadotropin. Heavy alcohol consumption, but not the moderate one, it may affect sexual and reproductive performance in a reversible fashion. When they will stop, then their parameters will return to normal. Tobacco smoking and the cannabis consumption, they have been shown to reduce semen parameters, although the relationship between male smoking habits and fertility, it is not known. Although smokers in general, they may not experience reduced fertility, but men with suboptimal semen quality, they may benefit from quitting smoking, and this should be strongly encouraged. Other recreational drugs such as cocaine, amphetamines, and opiates, they may adversely affect reproductive performance due to decreased libido and erectile dysfunction. According to some reports, sperm DNA damage, which is secondary to oxidative stress, it may be the cause of between 30 to 80% cases of the male subfertility. So recent evidence suggests that antioxidant supplementations in subfertile males, including carnitines, Then vitamin C, vitamin E, selenium, zinc, and coenzyme Q10. They improve semen quality and live birth rates in couples who are undergoing fertility treatment. In pre-testicular causes, there would be hypogonadotrophic hypogonadism is rare and accounts for less than 1% of the male factor problems. It results from decreased production of FSH and LH, which is secondary to hypothalamic or pituitary dysfunction, which leads to failure of spermatogenesis and testosterone secretion by the testes. It may be congenital or acquired. Causes include craniopharyngiomas, like they will put pressure on the pituitary in the brain, surgery for pituitary tumor, head trauma, then hemochromatosis, Kallmann syndrome, and other congenital genetic syndromes of reduced gonadotropin releasing hormone secretion, like Prader-Willi syndrome or Lawrence-Mood-Baby syndrome. In the testicular causes, hypogonadotrophic, hypergonadotrophic hypogonadism. It results from testicular failure and leads to oligospermia and non-obstructive azoospermia with elevated LH and FSH, okay, with an elevated FSH level, and it implies isolated spermatogenic failure without Leydig cell damage. Causes of testicular failure, they include bilateral cryptorchidism, genetic disorders, systematic diseases, radiotherapy, or chemotherapy. However, in the majority of cases, like in 66%, the cause is unknown. The diagnosis is based on reduction in testicular size and elevation of the serum FSH levels. If there is varicocele, so what exactly is varicocele? This is a collection of dilated, refluxing veins in the spermatic cord, and they are found in 11.7%, you can say 11 to 12% of the men with normal semen and 25% of men with abnormal semen. The exact mechanism by which varicocele causes the problem, that is not well understood, okay? But theories include increased scrotal heating and altered testicular steroidogenesis. Among the post-testicular causes, obstruction, excluding vasectomy, accounts for 41% cause the causes of the oosospermia. That is one thing, okay? So the diagnosis is based on normal serum FSH levels, normal testicular volume, and evidence of complete spermatogenesis on biopsy. Causes include surgical trauma and vasectomy, then infections like chlamydia, gonorrhea, TB, and congenital bilateral absence of the vas deferens, as in cases of cystic fibrosis. Clinical management includes history and physical examination. Together with the semen analysis, they provide the basic information for the initial evaluation of most men. So, what are the components of infertility history in the male? How we should take a detailed history, because if the history is taken in a good way, then you can get some idea that why this problem is there, why there is male infertility. Take history about medical problems, then recent pyrexial illness, systematic illness like diabetes mellitus, cancer, infection. Ask about genetic disorders like cystic fibrosis, Klinefelter syndrome. Ask about surgical history, undescended history of then on examination, if you find undescended testes, archaeopexy was done, hernia repair, testicular trauma, torsion, pelvic bladder or the retroperitoneal surgery, family history, previous pregnancies with current and the previous partners, duration of infertility, previous infertility treatment, sexual history, erection or ejaculation problems, frequency of intercourse, everything should be asked. Take a good history of receiving medicines like nitrofurantoin, cimetidine, sulfasalazine, spironolactone, alpha blockers, methotrexate, colchicine, amiodarone, antidepressants, phenothiazines, and chemotherapy. Take social history if patient is using alcohol, smoking, anabolic steroids, and recreational drugs. Ask about exposure to the ionizing radiation. Any history of chronic heat exposure at work, home, then exposure to aniline dyes, pesticides, lead exposure, and that's all you need to ask in the history. So in addition to the normal general medical history, particular attention should be paid to history of undescended testes, pubertal development, genital surgery, or infection, fertility in the current or the previous relationship, and coital frequency, erection or ejaculation problems. On physical examination, carry out examination of the male is in all fields, like from general physical examination and then abdominal examination and the local examination. So the general appearance, it should be noted, including any signs of decreased body hair or gynecomastia, they are suggestive of androgen deficiency. Consider the height, weight, BMI, and blood pressure of the patient to calculate that what are the chances of this patient, because if the BMI is outside less than 19 or more than 30, that is also associated with abnormal fertility profile. Scrotum should be carefully palpated with the man in the patient standing. Testicular size and consistency should be noted. The presence and normality of the vasa deferentia, it should be confirmed. For size measurement and orchidometer, it can be used for volume estimation. A mean volume of 20 ml in the adult is considered normal. If an undescended testis is diagnosed, a patient should be referred to a urologist for further management. The epididymis, it should be examined for distension or induration. Engagement of the pampiniform plexus of the veins in the scrotum is indicative of a varicocele. Varicoceles are usually found on the left side and they may be associated with atrophy of the left testis, testicular size discrepancy, and the feeling of a bag of worms with a Valsalva maneuver, like patient is breathing against a closed mouth and we feel that there is a bag of worms, so it means that this patient has varicoceles. So varicoceles, they are best identified when the patient is standing. Okay, so this is the initial assessment of the male. Now, if we have to do the investigations, what should be done? Do semen analysis. So semen analysis is the most important investigation. So what we will do here, this is not a test for the fertility but a guide for minimal standards of adequacy. So the normal values, they represent the 5th percentile of the semen characteristics of the men and the natural conception within the chances of conception within 12 months of the unprotected intercourse. So in a number of different countries, they can have like different percentages like that. So we have to compare the parameters to the WHO's parameters. We will ask the patient to practice abstinence for 2 to 5 days. Okay, abstinence for 2 to 5 days. 2 to 5 days, but it should not be more than not late than this one, because then the parameters, they will decrease. 5 days, because sperm parameters, they will change. They will decrease. Okay, so not more than 5 days. That is the point. Okay, so the WHO says that the semen volume should be like at least 1.5 ml, and then the sperm concentration should be like 15 millions per ml. Then total number of the cells in the ejaculate should be 39, and the total motility should be at least 40, but can be between 38 to 42. Progressive mortality should be 32. Total motility 40 and progressive motility at least 32%. Normal forms 4%. Vitality 58%. No need to remember the range, okay? This is the final thing that you should recall. So one sample will be sufficient if normal. However, the man's sperm count they may vary considerably over time, and therefore if an abnormality is detected, a repeat semen analysis should be performed after 3 months or sooner if the initial test they show azoospermia. Sperm motility tends to fall with prolonged periods of abstinence for more than 5 days, and therefore it is recommended that semen for analysis should be collected after 72 hours to get the best results, but if the situation demands, you need to do that between 2 to 5 days, not beyond that time. The entire ejaculate should be collected and the sample should be analyzed within an hour of collection, because sperm motility it decreases after ejaculation. So better to take the sample once the patient is inside lab. Regarding the endocrine test, so evaluation of the hypothalamo-pituitary gonadal axis, it can provide valuable information regarding sperm production. FSH, LH, testosterone, and the prolactin, they should be measured in men with sperm counts of less than 5 into 10 raised to power 6 ml. That is one thing. 10 to 6 ml. Then the test 10 raised to power 6 if they're less than like 5 million. Okay, because in 1 ml there should be 15 million sperms, but if there are less than 15 million sperms, this is 10 raised to power 6. So that is the point. Then we should investigate them, because it means like this is severe oligospermia. Testosterone levels they undergo diurnal variation. They are highest in the morning, and therefore random measurement it should be interpreted with caution if the result is borderline. FSH it reflects sperm production. Okay, FSH it reflects sperm production. Low testosterone levels with a high FSH and LH they indicate primary testicular failure, whereas low testosterone level in combination with the low LH and FSH levels it will indicate a central defect with secondary hypogonadism. This point is very important. If there is low testosterone but FSH and LH they are high, it means there is primary testicular failure, because high FSH and LH is present in the system but only testes are not responding. Okay. On the other hand, if we have low testosterone levels and there is combination of low LH and low FSH levels, it means there is a central defect with secondary hypogonadism, because LH and FSH they are coming from the anterior pituitary. So there is hypogonadotrophic hypogonadism of central origin. Azoospermia is in combination with normal hormone levels, it suggests obstructive causes. There is azoospermia in the semen analysis and the hormone levels are normal. So then you should expect that there is some blockade in the passage. So some obstructive pathology is there. Other indications for serum endocrinology testing, these include evidence of impaired sexual function, like person is impotent, and then reduced libido, and clinical symptoms of endocrine disease, for example, hypothyroidism. After this initial assessment of semen analysis, we should do genetic evaluation. Subtle changes, genetic abnormalities, they can present as male infertility. So a karyotype is indicated in cases of severe oligospermia or azoospermia, because these men they are at an increased risk of structural and sex chromosomal abnormalities. Klinefelter syndrome is the most frequently detected sex chromosomal abnormality. As many as 10 to 15% of men with azoospermia and 5 to 10% of the men with severe oligospermia they have underlying microdeletions in one or more gene regions which are implicated in spermatogenesis on the long arm of the Y chromosome. So this region is represented as VQ. Okay, this region is represented as VQ. So this region includes azoospermic factor locus, which contains three subregions. These subregions are azoospermic factor A, B, and C. So A's RFC microdeletion, they have deletions, they have good prognosis for surgical sperm recovery. Congenital bilateral absence of the vas difference, it can be associated with cystic fibrosis carrier status, and therefore men with non-palpable vas difference, they should be tested for mutations in the cystic fibrosis gene, as indeed they should all men with the idiopathic obstructive azoospermia, they should also be tested for cystic fibrosis gene. Azoospermia is there, we need to test for the cystic fibrosis. If nothing is found yet, we can go for imaging. So scrotal ultrasound, it should be performed if an abnormality such as testicular tumor is detected on physical examination. If an absent vas is detected on examination, a renal ultrasound scan is recommended, as up to 30% of such men, they will have a renal abnormality. So renal ultrasound should be done. On testicular biopsy, why we should do it? Because it can help in the diagnosis of severe oligospermia and azoospermia and facilitate sperm recovery from where? Sperm recovery for intracytoplasmic sperm injection. It's used, okay, for using ICSI. Biopsy can be done by an open or percutaneous needle approach, and it is used to obtain a small piece of testicular tissue for histological examination. Testicular biopsy specimen, it can be classified histologically. It can be normal, like the appearance, number of the cells, and complete spermatogenesis. Or it may be like hypospermatogenesis. When will be hypospermatogenesis? Like all cell types, they are present and in the correct ratio, but at reduced cell numbers. Cell numbers is reduced. Then there can be maturation arrest. It means failure of spermatogenesis beyond a certain stage. It can be early or late. Then patient can have only this Sertoli only cell syndrome. It is also called De Castillo syndrome. So the sporting cells, which are the Sertoli cells, they will be present, but no germ cells. Only the sporting cells are there and no germ cells. But in the Sertoli only cell syndrome, if we can do certain things, I will tell you in a while. In some cases, complex mixtures of the pathological patterns, they may be present. So we need to do biopsy of the Sertoli cell, and if a male has this condition, and then we can see that maybe we can retrieve the cells in very early stage of development. That is the point, okay? Then we can do other sperm function test. So routine semen analysis, it provides information about spermatogenesis. But what happens? But it gives little information about the functional ability of the sperm. That is the point, okay? So about the sperm, then a number of the tests, they have been developed to assess this. These tests include postcoital test, the sperm penetration assay, and the hemizone assay. The general consensus is that they are of limited value from a practical point of view. and they are therefore not used routinely in clinical practice. Sperm DNA fragmentation, it has been shown to be a robust predictor of assisted reproductive outcomes. Sperm DNA tests such as the sperm chromatin structure assay, the comet assay, and the tunnel. Tunnel is like terminal deoxynucleotide transferase mediated UTP, and this is the NIC and labeling. This is also a type of assay like tunnel assay. It will assess sperm DNA integrity. Short form is both as diagnostic test for male infertility and prognostic test for the outcome of assisted reproductive technologies. Their clinical application, however, needs further evaluation and improvement. So we have carried out assessment. Then what treatment options do we have? So treatment option where you see some hope, we can offer expectant treatment. Like if the age is young and there is no problem, then we can offer expectant treatment. Like they can wait for something depending upon the age of the couple. Second option is to offer medical treatment. So medical treatment, it can be given like specific hormonal treatments. They can be effective in known endocrine disorders such as hyperprolactinemia, hypothyroidism, and congenital adrenal hyperplasia. Hypogonadotrophic hypogonadism, it can be treated successfully with gonadotropin releasing hormone or exogenous gonadotropin. In general, though, medical treatment, it has a limited role in idiopathic male infertility. Idiopathic, where the cause is not known, so we are giving general treatment. In cases of primary testicular failure, like we said that where the gonadotropins like FSH and LH, their level will be high, but the testosterone, it will be low. There is no effective treatment to restore fertility in primary testicular failure. Men who are undergoing treatments that contribute to infertility, such as chemotherapy, they should be offered the opportunity to cryopreserve semen. Alternatively, surgical sperm retrieval with assisted reproduction or donor sperm, it may be considered. Sometimes urological surgery is required, like if the person has undergone vasectomy, then he can ask for reversal of vasectomy. So the success rate for vasectomy reversal, it depends upon the skill of the operating surgeon, surgical technique, and the time from the initial surgery. Patency rates, they seem to decline with increasing time due to increasing rates of antispermic antibody development and secondary epididymal obstruction. Surgical sperm retrieval can be offered from the like the sperms, they can be retrieved from the testes or the epididymis for use in IVF or ICSI. Common indications include obstructive causes, severe male factor infertility, or ejaculatory failure. So in all of these three conditions, you should offer IVF or ICSI. Techniques for the sperm retrieval from the testes, these include testicular sperm aspiration called TISA, testicular sperm extraction, and microsurgical, this TISA, which means that testicular sperm extraction. The results of a single biopsy, they may not be indicative of the spermatogenic process in the whole of the testis, and multiple biopsies may be necessary. Sperms from the epididymis can be retrieved by microsurgical like MESA or percutaneous like the MESA. Epididymal sperm aspiration under local anesthesia. Testicular biopsy, it should be done in a tertiary center with the facilities for sperm cryopreservation, and success rates for surgical sperm retrieval of almost 100%. They have been reported in obstructive cases with low rates of approximately 50% in the non-obstructive causes. If a varicocele is there, the degree to which varicocele repair improves pregnancy rates and the success of assisted reproductive technology, it remains controversial. The NICE guideline recommends that men should not be offered surgery for varicocele as a form of fertility treatment because it doesn't improve pregnancy rates. However, recent evidence from the randomized trial control indicates that varicocelectomy in infertile men with impaired semen parameters and the palpable varicoceles significantly improves semen characteristics and the chance of pregnancy within 1 year of follow-up. So after this, we need to see that can the assisted reproduction help us? So the various procedures can be done, like intrauterine insemination. It involves the placement of washed pellet of ejaculated sperms within the uterine cavity. So thus we are going to bypass or negotiate the cervical barrier, and it can be performed with or without ovarian stimulation. Indications include male factor infertility, immunologic infertility, and mechanical problems of sperm delivery such as erectile dysfunction or hypospadias. IUI is used in mild forms of oligoisospermia. However, specific semen criteria for its use they have not been standardized. So monthly conception rates of 8 to 16% they have been reported for IUI. So how many rates? 6 to 8 to 16%. That is significant because it is producing some effects. So however, its efficacy has been questioned by recent studies. NICE currently recommends the use of up to 6 cycles of unstimulated intrauterine insemination in mild cases of male factor infertility in order to reduce the rate of multiple pregnancies. IVF and the ICSI. Although IVF it can be used to treat milder forms of sperm abnormalities, more severe forms they will require ICSI. So more severe form means when 2 of the sperm parameters are abnormal, then you should go for ICSI. ICSI requires ovarian stimulation, so oocyte retrieval and sperm preparation as for the IVF. It is used for uncorrectable or severe forms of male factor infertility including oligospermia and asthenoteratozospermia or following birth or following fertilization failure in a previous IVF cycle. So all of these are indications for ICSI. Average pregnancy rates of 33% per embryo transfer they have been reported after ICSI. Regarding ethical issues, as ICSI bypasses the natural barrier to fertilization, it raises one important matter of concern, which is the potential genetic risk associated with this process and the propagation of the genetic defects that cause the infertility. This has ethical implications, especially with respect to the proportion of the genetic defects that may resurface in the male offsprings of the treatable infertile men. This could potentially lead to the creation of a population of subfertile men. Recent data suggests that offsprings which are born to the infertile couples using ICSI, they have higher incidence of chromosomal abnormalities than do the children who are naturally conceived. So the background risk of developing congenital abnormalities is 2%, and if there is male infertility and we are doing ICSI, then additional 2% risk is seen. So the overall risk of having abnormalities will be 4%. So that's all you need to remember about male infertility.